Good morning. My name is Dorene Rentz. I'm a professor of neurology at Harvard Medical School and a practicing clinical neuropsychologist. I am delighted to be with you virtually for this Dementia with Technology seminar. And I want to thank Dr. Josh Grill for inviting me to be a part of this. Today I've been asked to talk about computerized cognitive assessments. These are my disclosures. They don't really bear on anything that I'm going to be talking about today. You know, times have really changed when we think about technology. I remember back in the day when there were only mainframe computers, and this is a picture from the 1970s when a computer actually took up an entire room, and you were able to do some of the simple things that we can do on our iPhone today. It required a lot of real estate in order to be able to do that in the past. I actually wrote my dissertation on a VT180 that you see right here. It was a very simple computer that had an external disk drive. And then around the same time that I was at the University of Chicago, the Apple came out with this version that you see down here in the left side. And I remember everybody had one of those at the University of Chicago. Later on, I actually got one of these first IBM desktop computers. But since then, things have really changed. I can remember when a telephone, you had to carry it around in like with a backpack. It got to be smaller, and we all remember the flip phone. But now you see that we have tons of computing power in a simple laptop, a tablet computer, your iPhone, or a smartphone, and now even within a watch. But can we use this technology to actually measure cognition, the way people think and remember things? What we've learned over the past 20 years is that the changes in the brain related to amyloid, the amyloid protein and neurofibrillary tangles are occurring 15 to 20 years before someone becomes forgetful. And what we found is that these changes in the brain are occurring while people are still cognitively normal. Once the disease begins to progress, you can receive a diagnosis of mild cognitive impairment or Alzheimer's disease. But I've actually spent my career looking at this asymptomatic phase. And how do you disambiguate changes that occur normally just because of aging versus those that may herald a neurodegenerative process such as Alzheimer's disease? And the question becomes, our paper and pencil tests that we use now to measure cognition is very good at distinguishing between people who are normal versus people who are in the early stages of mild cognitive impairment or dementia. But the question becomes, can digital tests or digital technology bring us closer to understanding the subtle changes that may be going on with this early amyloid and tau burden? So we began to look at this probably now 10 years ago when we worked with Cogstate to put cognitive tests on an iPad. And this work was actually used in the A4 study, which was the very first prevention trial for Alzheimer's disease. And my supposition at the time was that maybe technology would be able to detect the subtle executive or processing speed changes that may be indicative of early Alzheimer's disease that go undetected with our standard paper and pencil tests. So we put together this group of tests. One was a behavioral pattern separation test that Craig Stark had used in an MCI trial that showed sensitivity to a treatment effect. We also put together the test that I helped develop called the Face Name Associative Memory Exam, which has people remembering names and faces. And we added it to the Cogstate Brief Battery. And we put all of this onto a computer, and it became a secondary outcome measure in the A4 prevention trial. And the hope is that as we begin to learn how this technology can operate within a clinical trial, maybe this type of technology will be able to be used instead of our traditional paper and pencil tests. In order to do this, we had to make sure that the tests that we were doing on the iPad was actually correlated with our paper and pencil tests. And what we found is that there was a good association between what we were using in the primary Alzheimer cognitive composite and the various different components that we found in the computerized cognitive composite, or from now on I'll refer to as the C3. But even more than that, I was very interested in trying to understand, can you do these kinds of tests at home? As this technology, iPads, iPhones, get more and more prevalent in our homes, would we be able to do these kinds of cognitive tests at home rather than having to travel miles to go into a clinic in order to do them? And so this was one of the very first studies looking at the feasibility of at-home iPad cognitive testing. And what we found, in fact, 40% of this particular sample were actually people 80 years of age and older. Now, in order to do this study in these days, we had to send iPads home with the people, and we had to hope and pray that we got those iPads back because they were expensive for us in the research setting. But what we found is that 95% of the people were actually able to do 7 out of the 9 tests at home successfully. And that the majority of the successful completions were actually done by those 80 years of age and older. So that was a wonderful news for me to know that our older individuals weren't intimidated by the technology, but could actually do these at-home tests. And what we found out is that the tests that these individuals did at home was equivalent to the tests that they actually did in clinic before they took the iPad home. And so this was one of the first studies to really show that these at-home tests could act as a proxy for the supervised in-clinic measurements on the iPad. After we did the study with the iPads, the NIH Toolbox then, which used to have these tests on a desktop computer, also transferred this technology to the iPad. And again, we have a series of different tests, both memory and executive function and processing speed, that now can be done on the iPad. And of course, we had to run a study to compare which one was better, our C3, the computerized cognitive composite, or the NIH Toolbox. And we looked particularly at the memory measures on these tests because my concern was that I wanted to be able to detect these subtle cognitive memory changes that may be related to preclinical Alzheimer's disease. And what we found out is that the memory tests that are actually on the C3 were better than the memory test that's on the NIH computer, the NIH Toolbox. And subsequently, what's happened is that the face name memory test that we put on the C3 is now being incorporated into the NIH Toolbox and also into the mobile toolbox, which is being designed on a smartphone. So simple little tests like this are beginning to have more widespread interest and use, particularly during times of COVID, when we found out that it's very difficult to bring people back into the clinic to do testing. And we wouldn't be losing any data if people were able to do this kind of work at home. So Kate Papp, my colleague here at Harvard, my colleague here at Harvard, she began to look at how the computerized cognitive composite, the C3, did in the A4 study. Remember, I had said it's a secondary outcome measure. And what we found is that a composite of all of the tests that you find in the C3 has pretty much equivalent effect size as our standard paper and pencil tests. So again, we're moving closer and closer to the use of this kind of computerized technology for measuring cognition, even in a clinical trial. But I've also been exploring something a little bit different that gets us even closer to how people think. And we began partnering with people at Digital Cognition Technologies for the clock drawing test. Now, clock drawing has been around for over 100 years, and some of you sitting in the audience today will probably even remember doing a clock, even in your primary care office. And it's been around not only for 100 years, but it is really quite sensitive in being able to detect people who are healthy from those who may be in earlier stages of Alzheimer's disease. But what if you could digitalize it? So what we did is we used some technology developed by Dr. Randy Davis and Dr. Dana Penny, looking at doing the clock drawing with a digital pen. Now, what the digital pen does is it has a camera at the end of a pen. It looks like any other pen that you would use, except now it's able to measure hundreds of thousands of pen strokes to actually get at how someone actually completes a task, rather than that they merely completed the task appropriately. And so what you can see here in the drawing is that while this clock looks normal, it may show subtle nuances of difference that may actually be predictive of people in early stages of Alzheimer's disease. So what we did is we took 300 individuals from the Harvard Aging Brain Study. All of them had amyloid and tau PET imaging, and we began to look at how sensitive this kind of digital biomarker could be in both predicting people who were normal from those who were MCI, as well as looking at normals who may have high amyloid versus low amyloid burden. And what we found is that the digital pen is actually quite good at distinguishing diagnostic groups. So in this first graph up here at the top, what you can see is that the area under the curve for the digital clock is actually 0.86. That's the green line that you see here. It's not as good as the paper and pencil tests, which we call the primary Alzheimer cognitive composite. But the take-home message is that we were actually able to get very good sensitivity and specificity for distinguishing the groups in 5 minutes versus 30 minutes. And so when you're in a primary care office, they don't have 30 minutes to be able to do cognitive tests. Could you be able to give them a simple drawing task that would give primary care physicians the notion of who is more at risk and should be referred for more tertiary care? When we looked at the digital pen's performance among clinically normal individuals, these were people who had amyloid and tau PET scans. What we found is that the digital clock summary score was actually better than our paper and pencil tests for detecting who was amyloid positive versus amyloid negative. Again, both are good, but it's very promising to know that some of these digital biomarkers can actually be sensitive at detecting who is more at risk, and also cheaper than a $7,000 PET scan. But the more important thing is that we found not only did the digital clock summary score was it related to both amyloid and tau burden, But we also found that it was the more nuanced features of spatial reasoning that actually was more sensitive to this amyloid and tau deposition. Now, what I mean by that is that what the digital technology allows us to do is to drill down into cognitive processes that really go unobserved when you're just doing paper and pencil tasks. And in this case, spatial reasoning actually involves how you put the numbers around the face of a clock. What kind of order do you actually use? Do you do 12, 6, and 3, 9? Or do you just randomly do the numbers around? All of these things actually have meaning. How do you place the hands? How do you draw the circle? So it was all these various components of spatial reasoning within that digital clock summary score that actually was more highly sensitive to amyloid and tau burden. Also, what we found is that the digital clock summary score was more highly related to amyloid deposition in frontal, parietal, and temporal networks than actually our paper and pencil tests, which you can see down here when you look at the brains pictured on the far right. The digital summary score actually is more highly related to the amyloid burden in these regions than even our paper and pencil tests. So the take-home message of some of this kind of technology is that we may be able to have a window into how someone completes a task rather than merely a total score or time to completion. And it's going to be these nuances of how someone processes cognitive information that may actually be more telling about amyloid and tau burden building up in someone's brain than whether or not you give them a test that has a total score. So we're very excited about this technology, and we've actually been working with Randy and Dana to look at it in relationship to other kinds of cognitive tasks. Now, I'm pretty excited about this task as well because it really gets at decision making. This is your typical maze test where you have to find, you're given where you start and you have to find your way out as quickly and competently as possible. Well, in this particular task, they designed it so that the very first time you're presented it, you really don't have any choices. All you do is just follow the road and get to the end. And you can measure with the digital pen how quickly you're able to navigate your way through the maze. But then they added a little bit more complex task that required various different decision points. And what's interesting about this task is that the solution is the same, but this time you reach a crossroad where you have to make a decision, which way should I go? And this really allows us to get at decision making in a way that we've never been able to do before. And what they found is that these decision differences, are actually able to dissociate between healthy controls and people with mild cognitive impairment and Alzheimer's disease. Now, we've also put this maze into the Harvard Aging Brain Study, and we're analyzing that data now to look and see how well the maze drawing, the digital mazes, is related to amyloid and tau burden in very early stages of Alzheimer's disease. Now, this is work that Dr. Kate Papp and Rebecca Amarillo are doing in designing associative memory tests. Now, these tests are actually done on a smartphone, and they are really trying to get at an ecologically valid task that people do every day. One would be related to street signs. Have you seen this sign before? Another is related to grocery prices. And then there is a category test where you have to say which item represents or is closer to the main category, and then the face name test. Again, the reason that she's focusing on these associative memory tasks is that they're very highly sensitive to people in preclinical stages of Alzheimer's disease. Now, she's still developing this, but I wanted to present it to you because it's another way of getting at memory processing that it can actually easily be done at home. And the first thing that she had to do is the same that we had to do with the C3, is you want to be able to make sure that the test that you're doing is associated with your traditional paper and pencil tests. And what she found is that it is that the branch composite is highly associated with the primary Alzheimer cognitive composite, as well as with the MMSE. But then what she's doing now is she's moving it into daily branch. Can you see learning curves that give you a hint as to how someone is doing over time? This is all very preliminary data, but what she's finding is that there are various tests that have less of a learning ability, and she's going to be now giving this test to people who have also had amyloid and tau PET scans to see whether or not we could measure learning curves in people who have a high amyloid burden. So in summary, what we know is that these kinds of digital tools, machine learning techniques, that they have a way of exposing cognitive inefficiencies for completing a cognitive task. And that it's these nuanced performances that may become more important than tests that only disclose a total score or time to completion. And where are we going to go with this? You know, eventually these digital tests should be honed for early detection of cognitive decline. And if we move this technology in that direction, they have a wonderful promise for triaging patients in the PCP setting and for potential referral to clinical trials. On the other hand, these digital tools, they need to be simple, they need to be easy to do, quick, and provide accurate diagnostic information. We also need to create these digital applications in a way that can capture change that is clinically meaningful, that really capture real-life information that's important to people, and that the tests will still need to be psychometrically sound and related to many of the gold standard paper and pencil tests that we currently use in the clinical setting. So I want to thank you for your kind attention. I want to acknowledge all the wonderful people that, even though we're working virtually nowadays, who work with me in the Harvard Aging Brain Study and the Center for Alzheimer Research and Treatment. Thank you very much for your kind attention.